So first of all, I'd like to thank the organizers for giving me this opportunity to share two interesting cases today. So this is my disclosure, and my objective is to briefly present two interesting, important case differentials for psoriasis. So this is the 5% that Dr. Bruce mentioned earlier. So case one is a case of a 25-year-old Filipino male who had a 6-month history of pruritic erythematous scaly plaques on scalp and face with noted progressive nail changes and reported arthralgia. He also had unintentional weight loss, but with no known comorbidities, no family history of psoriasis, no vices, and denied having multiple sexual partners. So these are the lesions of the patient on examination. There were multiple erythematous well-defined plaques with adherent scales on the scalp, extending beyond the hairline, and as well as in the seborrheic areas of the face in front, as well as in the sides. And there were noted significant nail changes that can be seen in psoriasis. So given the presentation of this patient, the initial impression at the time was psoriasis involving the scalp, nails, and the possibility of psoriatic arthritis. Fungal infection was ruled out with the negative KOH smear of the skin and nails, and PAS stain of the nail plate was also negative. So while the patient with the diagnosis was given topical steroids, and he was referred to rheumatology. But on follow-up, despite the topical steroid treatment, there was no improvement of the lesions, hence the biopsy was done. So on biopsy, it showed psoriasiform epidermal hyperplasia with lichenoid infiltrates of lymphocytes, histiocytes, and plasma cells, giving the diagnosis of syphilis. Nail biopsy also did not show psoriasis, and the further laboratory tests were done to look for other STIs, and these are the following reactive results. So this case is a case of a secondary syphilis in an immunocompromised patient with hepatitis B and C and HIV. So treatment was initiated. He was given benzathine penicillin, and antiretrovirals was started, and prophylaxis. So this is the patient 1 month after benzathine penicillin was given, with the complete resolution of the lesions on the face, as well as marked improvement of the lesions, syphilitic lesions on the nails. So the second case is a case of a 15-year-old female who had a 7-month history of erythematous, pruritic, thick scaly papules and plaques on the face, on the trunk, on the extremities, and genital area. She also had yellowish discoloration and hyperkeratosis of the nails. She also reported joint pains, and there was intermittent fever and easy fatigability. So on examination, these are the lesions of the patient. She had well-defined erythematous papules and plaques. Some were conical and hyperkeratotic with adherent scales located on the face and on the nape and the upper back as shown in these photos. There were also lesions on the trunk and arms noted on the elbow area, on the arms and on the hands involving the palms. And if you can see, there are also significant nail lesions on the fingers. There were also lesions on the lower extremities, as well as a thick lesion on her vulvar area. So the initial impression of this case was psoriasis of rheumatoid type with nail involvement and with the possibility of psoriatic arthritis. But because of the atypical presentation, skin biopsy was done on the first consult, and secondary syphilis was ruled out with the RPR non-reactive result. Baseline laboratory tests were also requested. So the management, while waiting for the result, was topical steroids, and the patient was referred to rheumatology. But despite the steroid treatment, there was progression of the lesions. You can see in these photos involving the entire trunk, as well as worsening of the lesions on the extremities. So biopsy results came back. It showed psoriasis vulgaris on one side, and on the other was interface dermatitis. So that prompted us to do further tests, and DIF showed consistent results with cutaneous lupus erythematosus. So further workup was done, so showing the following results. So she fulfilled the EULAR criteria for systemic LE. And so the final diagnosis for this case was psoriasis, rheumatoid type, and systemic lupus erythematosus overlap. So in summary, I presented two cases that poses diagnostic challenges because they presented with lesions similar to psoriasis involving the skin there were nail involvement and joint pains. However, red flags was recognized, indicating the need for further investigation. So red flags include the atypical presentation of the lesions, poor response to treatment, and presence of other systemic symptoms. So in this case, it was also highlighted the importance of doing a biopsy because it's an invaluable tool in confirming the other differential diagnosis. And in these two cases, we saw that syphilis and lupus erythematosus are two important differential diagnoses for psoriasis, and it's really important to distinguish them to prevent misdiagnosis and improper treatment. Because misdiagnosing syphilis delays antibiotic treatment, and if we give immunosuppressants for psoriasis in a syphilitic patient, that could exacerbate infection. And misdiagnosing systemic lupus erythematosus is critical because systemic involvement often necessitates urgent corticosteroid treatment. So in conclusion, we know that psoriasis, as shown in the earlier lecture, comes in various forms, and we should always consider broader differentials, especially in atypical presentations. And we must understand that psoriasis can coexist with other conditions, and we must respond to red flags. You know, if we see them, if there's poor response to treatment, unusual presentation, that would warrant further investigation. And biopsy as dermatologist is important when you are uncertain and if you want to rule out other diagnoses, because the goal is not just to diagnose psoriasis correctly, but to ensure that we do not miss other differentials or coexisting conditions that may require different therapeutic approaches. So with that, thank you very much for listening.